This is the pathophysiology of what we're kind of going to, and it's kind of, I'm going to go kind of quick through it. But basically, the trigeminal nucleus caudalis extends to the dorsal horn for C3, C4, and C2 pain, innervation resulting in neck and posterior head pain. And basically, the trigeminal nucleus, which does the sensation for the whole face, is that nucleus where that neuron originates, sits right in the very base of the brain, right next to the same bodies of neurons that supply sensation to the back of the neck. And they're just sandwiched right together. And the sensory relay center, it's part of the trigeminal nucleus caudalis that extends down into the brainstem. You can get referred pain, into all of these areas in the back of the neck, around the ear, and the most common in the posteriorly being the greater occipital nerve, pain in this area. These are all other sort of minor sites that we talk about at meetings because we really haven't been described. As Debbie mentioned, there are 4 sites, 3 in the front, one of which being the nose, and then one in the back of the neck, which is the greater occipital nerve that we decompress. These lesser occipital nerve, greater auricular nerve, those and the third occipital nerve, which is not pictured there, those, Dr. Guyron's done anatomic studies on I don't know how many cadaver heads he did for each of those nerves, but describe them, with calipers exactly how far from the midline they are. So he's done the anatomic studies on all of these nerves. I have operated on this one once, and then there's another nerve here that's not, Dr. Reed mentioned the auriculotemporal nerve, which is right in front of the ear, that I've operated on several times, which I think, and I've spoke with Dr. Guyron about the possibility of that being a 5th site. That's probably the most common of these other peripheral nerves that I've encountered anyway. From that sensory relay center, a reflex can come up and send parasympathetic innervation to the sinus area, which gives you those autonomic symptoms like lacrimation and runny nose, rhinorrhea. So here you have the vessels in the dura, which will dilate in response to the migraine generator, right, Debbie? Okay, and then it would, this would dilate, and then there's the release of those substance P, which is a pain mediator, as well as an CGRP, thank you, and the kinins. And those will cause further vasodilation and cause basically the sensory innervation, which is from the trigeminal nerve of these vessels. This will feed back into the center that caused the dilation to begin with and will cause this to become more irritable, which will then send more messages for it to dilate. So as you can imagine, there's this feedback loop. But the problem is in here is the fact that this is excitable, which causes this to dilate to begin with. And then it excites itself, if you will, and it creates this circuit, this what we call a positive feedback loop. Now the interesting thing is that there are lots of influences on when and why the signal gets sent up to these blood vessels that cause that initial wave of depolarization and the vasodilation. And what we feel is that the peripheral triggers, meaning these nerves that are impinged upon, or the airway vibrations, those are, I mean, the nose is innervated by the trigeminal nerve, the whole face is the trigeminal nerve, and the nerves back here are right adjacent to the trigeminal nerve. We've just given them a different name called the greater occipital nerve. And the sensations that travel through those sensory nerves, they come in here, and somehow they cause this to become excitable. And once it reaches a certain threshold, then it will send a signal up to these vessels for them to dilate, and you start that circle, you start that cascade. And once this occurs and this loop is going, then some of the pain essentially is sent out along the fibers and is referred into all of these areas that may have contributed to the original excitability here by the mechanism in each different site. So you sort of have, you have 2 things going on. You have irritation in the area which is causing the migraine to start, even though you may not be having any pain there. It's just that the nerve is being pinched as you frown or as you tense your neck. And then once the cascade starts, then that pain generally, and in my opinion, comes back out the same areas where it's being triggered. Now, I was going to ask you something about that, Debbie, you know, we tend to deactivate the trigger zone where they're having the pain, but the pain's really kind of has come later. And that's why I think, as far as the question about the local anesthetics, you know, if someone's in a full-blown migraine headache, they're having pain in that area, the local anesthetic may not give it, you know, make it go away because the pain's coming from the inside out. What we're trying to do is we're trying to calm those nerves down so that they don't excite this area and start this pattern. So, and our current approach is to sort of trust the area where the pain is and sort of presume that that may be also the area that's triggering it, and it's worked, is basically the bottom line. So that is kind of what we're trying to do, is to break up this feedback loop. And once it's broken up, then this area can kind of settle down, and then your migraine threshold goes way up, and you have to like have 2 glasses of wine, stay up all night, and watch 6 hours of TV, and then you might get a migraine. I have one guy from New York who I saw, and when I saw him, he's like, no, I can't listen to music, I can't have my friends around, you know, my girlfriend, you know, she can only come like over to the house like 1 day a week, you know, I've been shutting myself inside and stuff. And I operated on him, and it was like, you know, 6 months later, or maybe it was even a year later, he's a couple years out now, he's like, you know, they're coming back some, you know, I'm having some problem, and you know, and I said, well, what's going on? He's like, well, I can't watch TV. And I was like, well, so you can't watch it at all? He's like, well, no. And he kind of laughed. He goes, well, you know, if I watch like on a Saturday, if I watch like a lot of TV, then I'll get like a really bad headache that day. Not as bad as it used to be, but pretty bad. And I'd say, well, how much TV are you watching? And he'd say, well, like 8 to 10 hours. And before he came to see me, he literally couldn't, if he said if I watched the TV at all, something about the light would set things off. And you know, and then of course he's only, you know, 60% improved, but he's watching 10 hours of TV and still getting a headache. So these are the different treatments, and I'm just going to blast through these. Emergency treatment, different things that, you know, this is actually a pretty good one. A lot of people end up getting, when they go to these big headache centers and get admitted, they end up getting IV magnesium, steroids. I have one patient here in the room that's been treated with steroids for cluster headaches, and you know, a lot of these medications have certainly their own side effects. Prophylactic treatment, this is great if you have high blood pressure anyway, probably should be on it, and if that takes care of the headaches, then great. Same with the calcium channel blockers, the antidepressants. These work primarily through their anticholinergic effects, where they shrink down the mucosa, they dry out your mouth, they dry out your nose. You can breathe great, but you're chronically craving water. And it may not be because it's getting rid of your depression, it's just because they're, you know, these medications are so much stronger than Benadryl ever could be for an anticholinergic. They're just extremely strong that way. Anticonvulsants, some of which are, require MRIs to look at your retroperitoneum and your lungs to make sure you're not getting pulmonary fibrosis, which is like a fatal condition. So these medications certainly are not benign. Abortive therapy, these are amazingly effective for so many people. They are really amazing drugs. They just don't necessarily work forever, and they don't work for everybody. This is the mechanism. This is that CGRP, neurokinin, and the substance P, and basically those triptans, they just interrupts, and so it interrupts the dilation of this blood vessel, which causes it to constrict, which causes the headache to go away. But you got to take them quick. You got to take the triptans as soon as you notice it coming on, and they recommend you start with the highest recommended dose. These are some of the sensations people get: warm, hot flashes, tightness, tingling, flushing, feeling of heaviness or pressure in the chest is what I've heard. You know, patients that come in and they're like, you know, I feel like I'm gonna have a heart attack every time. And I go to the ER. It's not because I can't handle my headache, because I've always been able to handle my headache, but it's because I feel like I'm gonna have a heart attack. My mom had a heart attack when she was 47, and I'm 44. I had this one patient, and literally this is exactly what she told me. And we fought and fought and fought with insurance, and it didn't. They had Anthem, and it didn't work. But one of these days, it's gonna work with that particular company, because it's worked with others.